Dr. Fatma and my fellow friends. We are from Group 4, and the topic that was given to us is Cognitive Disability Frame of Reference. The content of this presentation is first introduction that will be explained by me, Hafsa. Then Amira will explain the theoretical basis, and Farah will explain about the goal of this frame of reference. Then we have description that Khadijah will explain about it, and lastly Intan will talk about the case study. So first, let's know what is cognitive disability frame of reference. Impairment in cognitive disabilities and social functioning are common characteristics of psychiatric patients. This cognitive disability was developed by Allen, and it was published in 1985. So this cognitive disability frame of reference is one of the leading theories in psychiatric occupational therapy, and it has been widely used. The cognitive disability model had its beginning in the late 1960s when Claudia K. Allen and her co-worker first observed patterns of performance difficulties in adult patients with mental disorders. So in 1970, Allen started a cognitive disability theoretical frame of reference that described a sequence of 6 levels of abilities called Allen's cognitive level. So the cognitive level is like a hierarchical sequence of sensory-motor abilities that were similar to Piaget stages of cognitive development. Later, this theory was published in 1985, which provides a guideline for modifying the cognitive demands of activity to match with individual abilities, which is the person's cognitive level. So, the definition of cognitive disability by Allen is considered a limitation in sensory motor based action that originate from structures of the brain, whether it is chemical or physical structures, that can cause impairment in routine task behavior of the patient.
Okay, now we move to the theoretical basis of cognitive disability frame of reference. Okay, this frame of reference derives its theoretical underpinnings from neuropsychology, cognitive psychology, and also biological psychiatry. Okay, this frame of reference contains a few assumptions. Okay, the first assumption is cognition underlies all behavior, which means that it assumes that thoughts are the primary determinants of our behavior. So our thoughts process or mental affect the way in which we behave in our everyday life. Okay, information processing is a common description in a mental process. Same here, like Claudia Allen's 1985 viewed that the brain as an information processing system, and the Allen 6 cognitive level that she developed also stated to be in agreement with information processing theory. Okay, what is information processing theory? Okay, it is a cognitive theory that focuses on how information is encoded into our memory. Okay, this information processing theory have two basic concepts. Okay, the first concept, which is chunking and the capacity of a short-term memory. Okay, the second concept, which is information processing, use the computer model use the computer as a model for human learning, which means that the processing involves gathering information and representing information, which also known as encoding, holding information, also known as retention, and getting the information back when we want is also known as retrievals. Okay, how is this information processing theory is related to the Allen's cognitive level? Okay, I will further explain the assumption of number 2, 3, and 4, and then you will more clear on how this information processing theory is related to this Allen's cognitive level. Okay, the second assumption of this frame of reference, which is the brain pathology compromise cognitive process in a manner that can be observed in a normal life activities. Okay, it describes that any disorder or disease or conditions affecting the brain, example like tumor, stroke, or traumatic brain injury, it will affect our cognitive process. Okay, the effect on the cognitive process also can be seen through the way we behave in our daily activity. For example, in Allen's cognitive levels that she made, she defined cognitive level by qualitative differences in input, in output, and also in throughput. Okay, what is input? It is like sensory cues that person captures and the sustained attention that the patient have. Okay, for the qualitative differences in output, which is the result of motor actions that persons execute, and lastly is the qualitative differences in throughput, which is the sensory motor association formed in the brain between the sensory cue and motor actions. Okay, from these qualitative differences, we can see a person's ability changes that occur due to this kind of pathological condition that affecting the brain. Okay, the third assumption, which is the reorganization of cognitive abilities, follows a predictable and hierarchical sequence. Okay, as you can see, in a disease of the brain in which recovery can be expected, for example, like in a stroke patient or traumatic brain injury patient, the recognition of cognitive abilities follows a predictable and a hierarchical sequence. Same goes to a disease marked by progressive deteriorations, as in dementia. The loss of cognitive abilities follows a predictable sequence, but it is in a reverse sequence. Okay, like in the Allen Cognitive Level Screening Tool, SCL, it proposed a hierarchical of 6 cognitive levels that identify those dimensions of talk that differentiate and explain functional limitations in day-to-day activities. These cognitive levels describe this cognitive level describe the varying effect of brain pathology on normal life activities, provide a means for analyzing the relative difficulties of any activity in terms of the requisite thought patterns and delineate factors within the environment that can be modified to help the individual carry out preferred activities in as independently as possible. Okay, for the last assumptions of this frame of reference, which the cognitive and behavioral response will become more effective when the environment are presented with the level of cognitive functions, um, which means uh, which means that regardless of the level of cognitive ability of the person's cognitive process are maximized and behavioral response become more effectively organized when environmental stimuli are presented to the impaired person in a manner that match his or her level of cognitive functioning. Okay, this cognitive disability approach involve knowledgeably modifying the cognitive elements of the activity and the environments in order to place them in order to place them within an individual's range of comprehension. Okay, when activities and the environments are modified so that an individual can comprehend what is involved, it is hypothesized that the performance will be successful. Okay, cognitive maximization occurs in the context of activities and environments that are designed to match the carefully assessed cognitive abilities and impairments of an individual. So, appropriate combination of such activities and environment can contribute significantly to enhance functional independence and quality of life of a person. And for examples, when a person have dementia, this um, demented person might have problems doing a task in a sequence or have a memory problems. Okay, environmental stimuli like provisions of environmental cues, for example, like visual signs, like calendar or uh, um, audible alarms, or we also can attach notes of the sequence of the activity at the activity environment or labeling the doors, drawers, cabinets, and dressers. This all might be very helpful in cueing the person about where to find the items or when to initiate an activity. Okay, this might very helpful to develop the best effective behavioral response or cognitive process in demented persons and also other cognitive problem patient.
Okay, now we will move on to the goals of cognitive disability model or cognitive disability FOR. Okay, firstly, the Allen's cognitive disability model provides a framework that addresses the cognitive impairment and functional disability from a multi-component perspective. This means this cognitive disability model specifically addresses to the functional and behavioral consequences of cognitive impairment. And this model also proposes an information processing model of the etiology of the functional impairment, which identify different information processing patterns revealed by the different pattern of functional performance. Okay. The exact goal of the cognitive disability FOR are: first, to provide a sound theoretical basis to enable occupational therapists to further understand the relationship between mental disease and functional ability. And second, to identify information processing abilities to determine whether the individual can perform functional activities safely and successfully or not, as well as to measure the extent to which cognitive impairment need to be compensated for. And next, this cognitive disability FOR also used to prescribe intervention strategies for people or for persons who, as a result of cognitive dysfunction, cannot are not able to carry out their normal life activities. And lastly, the ultimate goal in this cognitive disability FOR is the maintenance of the existing skills with the possible development of newly learned coping strategies. Okay, this cognitive disability FOR derives its theoretical underpinning from neuropsychology, cognitive psychology, as well as the biological psychiatry. Okay. For the short-term goals in cognitive disability FOR is aim to match the current mode of performance, while the long-term goals in cognitive disability FOR are based on the prediction of change in the performance modes. Okay. Moreover, there are specific treatment goals in cognitive disability, which these will be identified relative to the 6 cognitive levels identified by Allen. And for many of the DSM, the Diagnostic and Statistical Manual of Mental Disorder diagnostic categories. Okay, the six cognitive level will be further explained in the description of cognitive disability FOR by Khadija. And lastly, the knowledge of the level of function and understanding these six cognitive levels will assist us occupational therapists in developing client-centered strategies. And that's so we can identify the patient remaining abilities and also strengths. And moreover, we also can identify the safety issues as well as the appropriate level of supervision that our patient needs.
Moving on to the description of cognitive disability frame of reference. So this frame of reference can be used to assess and to determine what cognitive level a client would best fit and can be used as a guide but not as a permanent label. Okay, so in cognitive hierarchy, cognitive function is classified on a scale of 6 levels ranging from the severe disability at the first level and to normal ability at the 6th level. Allen cognitive level. We will begin with the first level, which is automatic actions. Okay, so client is conscious and responding to internal stimuli. And then client does not experience the self as separate from the environment. And their behavior appears to be instinctive or habitual and then often restricted to bed, grooming, dressing, and bathing, and other nursing care must be provided, which means they are dependent. And then intervention that we can use for this level is sensory stimulation. Okay, so the next level is level 2, which is postural actions. Okay, so patient motivated to maintain a state of comfort and appears to have a primitive sense of self and may be able to assist the caregiver in some nursing tasks. And intervention that we can use for this level is movement or exercise groups based on imitation of the client. So next level is the third level, which is manual actions. Okay, so client can respond to tactile cues with manual action and can engage in repetitive, seamless, pointless, or inappropriate action. And their attention span can be maintained up to 30 minutes and is influenced by the material given to them. In this level, they may need much reminding to seek a task to completion. And also, intervention that we can use to this level is we can allow patients to use all equipment given without assistance. Next level is the fourth one, which is goal-directed action. So patient will relies on visual cues and tends to comply with the actions needed to achieve a short-term goal. Their basic activity daily living are intact and they may ask for assistance. And established daily routine can be followed. So attention to projects can be sustained for about an hour. And intervention that we can use to this level is reinforce familiar routines and perform repetitive drillings. Okay, so fifth level is exploratory actions. So client use over trial and error and experimentation to solve problems. And then new learning is occurring and they may have difficulties with imagining long-term consequences of the actions. And then furthermore, in this level, vital tasks such as dressing, eating can be accomplished without having difficulty, but they may have poor social awareness. So interventions that we can use for this level is learning to improve the effects of their action to considering social skills such as empathy. So the last level is level 6, which is planned action. So in this level, it describes as absence of disability and client will use symbolic cues as a guide of motor action and can think hypothetical situation and further events also can be planned. And in this level, they also can be assumed as a normal person. Next, moving on to the assessment that we can use. There are three assessments we can use, which are the first one is Allen Cognitive Level Screens, ACLS. The second one is the Routine Task Inventory Expanded, RTIE. And the third one is Allen Diagnostic Module. Okay, so I will explain about the ACLS. So ACLS is a test that evaluates the ability of someone to make decision, evaluate the ability of someone to function independently, evaluate someone safely perform basic skills, and to learn new abilities. Also, the ACLS is based on Allen's cognitive level that I have been explained before, which is a scale that includes level from 1 until 6 that identify different cognitive abilities. Okay, so the second assessment is Routine Task Inventory Expanded, RTIE. So this is the evidence-based assessment. It is a semi-standardized assessment tool developed within a framework of cognitive disability model. So functional cognition is assessed based on therapist's direct observation of performance in naturalistic contexts or on the perception of the performance reported by the client or a caregiver using a checklist or standardized interview questions. Okay, so RTI can be taught as an activity analysis and a functional evaluation instrument that consists of four domains, which are physical skill, activity daily living, community skill, IADL, communication skill, and work readiness skill. The aim of this assessment is to promote the safe and routine performance of an individual's professional performance and also to maximize the individual's participation in the life situations. So the last assessment that we can use is Allen Diagnostic Module. So Allen Diagnostic Module use a dynamic approach to assess cognitive level while taking motivation and socialization into account. Performance Client's performance is observed during a group centered around a variety of standardized craft activities. Craft are viewed as being motivation and observation of response to instruction and sensory cues from materials and tools provide the basis for prediction about function in other occupations.
Okay, so I will continue with application for this FOR. So we include a case study for this FOR, which is about Mr. J, a 45 years old man, was suffering from severe depression. He lives alone on his own, must stop working as sales manager due to worsening of his condition. He is unable to visit and take care of his parents, and he feels guilty about it. He is unable to take care of his meal, forget to take his medication, has sleeping difficulty, and always forgetting to do home chores that he planned to do for that day. He is also unable to take care of himself, such as often exclude himself from bathing and grooming. He also complains about often misplacing his medication, glasses, and keys. He also cut off all his relationship with his friends and co-workers. So basically, from this case study, we can see that Mr. J has problem in performing ADL and IADL independently, such as bathing, grooming, housekeeping, and also preparing meals. He also has poor sleep quality due to difficulty in falling asleep, and he has problem in cognitive function, which he has a short-term memory problem. Lastly, he also has problem in social and communication skill. So, from this case study, what assessment from this condition? Okay, so assessment that we can use for Mr. J, the first one is Allen Cognitive Level Screen, which is ACLS. This assessment is to determine the cognitive level of the patient by evaluates the ability of patient to make decision, function independently, safely, perform basic skill in learn new abilities, which is this assessment has been explained previously by Khadija. And then other than that, we can also use routine task inventory, which is expanded version. This assessment can assess functional cognition, which based on therapist's direct observation of performance reported by clients or a caregiver using a checklist or standardized interview question. And this assessment to promote safe routine performance of an individuals, value occupation, and to maximize participation in life satisfaction. And next is assessment that we can use is Canadian Occupation Performance Measure, also known as COPM. This assessment can be used to detect self-perceived change in occupation performance problem over time in terms of his self-care, productivity, and leisure, which is suitable for Mr. J as he has problem in these three domains. And then, as I mentioned before, Mr. J has difficulty in falling asleep. So we can use Pittsburgh Sleep Quality Index or PSQI to measure quality and pattern of sleep in Mr. J. From this assessment, we can differentiate either Mr. J has poor or good sleep quality. Okay, next we will move to the intervention that we can carry out for Mr. J based on his problem identified from the case study and from the assessment. Okay, so the first problem that Mr. J having is a problem in performing ADL and IADL independently. For example, in bathing, grooming, home chores, and also meal preparation. So basically from this problem, the short-term goals that we will set is to improve ADL and IADL functional level of Mr. J. And for the long-term goal that we can set is to maintain maximum functional independence in performing ADL and also to promote good quality of life. So basically, intervention that we can use for this problem is by ADL retraining. So the method that we can use for Mr. J is we can establish a routine for Mr. J to carry out. This also will help Mr. J as he has short-term memory problem by follow the routine that we have established for him. And then we can also create a timetable for Mr. J to follow. And then in ADL retraining, we must show the process by demonstrate the activity step by step. So basically, Mr. J, our patient can carry out the activity step by step. And then we can also do a checklist for Mr. J to follow every day about what activity or house chores that he need to use that day. So we can ask patient to tick on the checklist about activity that he has carried out that day. And then we can also, during ADL training also, we can correct any mistakes that Mr. J has done so that Mr. J can improve himself when carry out ADL and IDL slowly. Okay, for the next problem is, as we can see from the assessment, Mr. J has poor sleep quality due to his sleep habits, which is he has difficulty in falling asleep. So basically, the short-term goal for this assessment for this intervention is to improve patient sleep quality, and for the long-term goal is to maintain good quality of sleep and also to promote good quality of life. So basically, what intervention that we can do for this problem is by education on good sleep routine and sleep hygiene. So basically, what is sleep hygiene? Sleep hygiene is any preparation that we need to do before we falling asleep. For example, patient must avoid taking caffeine drinks before sleep, and patient also can set a comfortable bedroom environment uh, that preferred by the patient, such as quiet bedroom, thick curtain, comfortable mattress or others. And then we can also um, ask patient to set a schedule for his sleep routine, which is set a time for what time he need to go to sleep, and avoid any electronic devices before he falling asleep. And then we can also encourage patient to take a warm bath before sleep, as it can help patient uh, in having a good sleep. Okay, next problem is patient have problems in cognitive function, especially in short-term memory. So the short-term goals for this problem is to improve patient short-term memory, and then for the long-term goal to enhance cognitive function, which is short-term memory. And then for this problem, we can do a tabletop activity, which is any activity that's suitable for Mr. J in terms of his condition and age that can improve cognitive function. So basically, this activity, we can grading the activity either by simple to hard, or also by speed of the task, which is slow to fast. So basically, this tabletop activity will help Mr. J to improve uh, his cognitive function, especially in short-term memory. So this tabletop activity must be benefits in helping Mr. J in improving his uh, short-term memory. Okay, for the cognitive level of the patient, which is we use Allen Cognitive Level Screen (ACLS) assessment just now. So as mentioned by Khadijah, we already for the each level there is a specific intervention that we need to use. For example, for this case study, patient got level 2. So the intervention that we need to do is movement or exercise group based on imitation. Okay, so for the last problem that patient has is he has problem in social and communication skill. The short-term goal for this problem is to improve social and communication skill, and for the long-term goal is to promote good social and communication skill. So the intervention that we can use for this problem is group activity. So group activity involve a gathering of a few patients that have similar condition to share and communicate with each other. So basically, this group activity not only will improve their social interaction and communication skill, but also can increase their self-esteem and self-confidence. So, patients will gather between themselves and interact with each other and communicate among them, and they will also share their experience and their condition with each other. So patient uh, feel will not feel isolate from others, as uh, they able to understand each other. So that's all from us. Thank you.